So thank you very much, Steve Morgan, and I am very pleased to be here to speak today about pharmaceutical policy. I want to thank the organizers of the meeting and editors of the book for this invitation. It was actually been an interesting opportunity for me to look back at some data about pharmaceutical cost control in Canada, and I was asked actually to provide a summary of effective cost control mechanisms as they've been applied in Canada, and so I'll jump to the punch, and here it is. Any questions? Well, I probably need to justify that these results in some way, so I've got 25 slides in which to do so in 20 minutes. I'm going to go back in time actually a little bit and look at a historical view of, first of all, drug development as opposed to drug spending. Was influenced by the introductory chapter that was circulated before this conference around the bending the cost curve theme, and one of the themes that emerged in that chapter was that there had been eras or periods of cost growth in Canada's healthcare system and some periods of retrenchment. I think in the pharmaceutical sector we have this interesting sort of very macroeconomic or very exogenous force on spending of medicines, and that is the rate at which drugs are developed globally. We know that medicines development is not a Canadian problem in a Canadian system. Canada only accounts for roughly 2% of the world market. In fact, now it's closer to 1% of the world market for pharmaceuticals, and we punch around that level in terms of our productivity of drug development. So the data here are American approvals of new chemical entities, 5-year averages over the past roughly 60 years. And the key thing to look at here is that there are in effect 3 eras of drug development, which will correspond, I think, to 3 eras of drug spending trends. One is the post-war therapeutic revolution that occurred starting in the 1950s and waning in the 1960s, as you can see, and ending up in a therapeutic kind of lull of the 1970s as, in a sense, the molecular roulette of the post-war era waned because there was less basic science of the time and more just fortune meets the prepared mind type of investigation. We saw a significant increase in drug development in the late 1970s through the 1980s and early 1990s as a function of an era of rational drug design. Advances in basic understanding of molecular targets and the ability to synthesize chemistry or chemicals gave scientists an opportunity to actually try to invent medicines or at least screen compounds for which they had at least some a priori anticipation of therapeutic effect. The decade of the 1990s is unique, and you can see in this data, it's actually quite stunning. In 5-year moving averages, it's way off the charts in some sense in terms of drug development. I don't have the time to go into it right now, but I can tell you that most of that spike, in fact, virtually everything above the number 20 over those decades is a function of what we would call Me Too drug development, the development of drugs that enter already crowded therapeutic marketplaces, and many of those drugs are actually entering markets that had been discovered or developed in terms of the chemical groups that approximately 10 or 15 years prior. But in the 1990s, there was still, I think, lucrative economic opportunities in those markets, which is why we see drugs come to market for them. So here's drug spending in Canada, of course, plotted against those numbers so you can have a look at it. I'm going to break it into several sections here. Briefly, in the post-war era, we saw what has to be considered a relatively steep slope in terms of drug spending in the country. This is manufacturer-level shipments, because back in the 1950s and 60s, we didn't have CIHI, so we don't have retail spending data. But you could see, consistent with the post-war therapeutic revolution, lots of spending, lots of attention in Canada and abroad about whether or not this spending was appropriate. In this era, there was already concern about excessive drug pricing, excessive drug promotion, excessive drug utilization. You know, the more things change, the more they stay the same. Fast forward, you actually see a bit of a lull in drug spending in Canada, and interestingly enough, you see this also internationally during the 1970s, and then a significant uptake in drug expenditure here and again in many other countries around the world starting in the 1980s, which is probably predictable by way of the rational drug design era, the modern therapeutic revolution bringing to market a whole host of new treatments that are truly effective relative to standards that had preceded them in terms of preventing disease or helping treat patients for conditions, even things like ulcer, which might otherwise have required hospitalization. And then the last era I'm going to point out, and you'll note that the scale on the left-hand side gets smaller, bigger and bigger over time, and the previous eras of drug spending inflation sort of shrink, because we have seen an exponential growth curve in spending, and certainly the last roughly 15 years, at least up until approximately 2008, in Canada and in many countries around the world, we've seen extraordinary drug expenditure inflation. In fact, I would pause at this slide alone and just mention that drugs over the period in this last era have been the fastest growing component of healthcare costs. They surpassed physicians in terms of the elements, the largest elements of health expenditure in Canada. They surpassed physicians in 1997, and physicians have not yet caught up, despite a slight bending of the cost curve for medicines, which I'll explain later on. So the other cost curve or cost problem that Canada may have is a level of provincial variation. There are extraordinary differences in spending on medicines across Canadian provinces, and differences partly in trend but mostly in levels. And this data, or the CIHI data on real spending per person in the provinces, you can see there's wide variation, something on the order of nearly 40% variation from one province to the other in terms of spending per capita, and significant variations in terms of cost curves. And I think that probably one of the reasons I was invited to speak here is that I'm from the province that represents the bottom line there. British Columbia has the lowest spending on medicines, so basically has had the lowest spending on medicines in Canada since the 1980s, and seems at some level to have slightly lower growth rates, although I'll show later on that if you adjust those data so that the axis reflects British Columbia's starting and ending point, the growth rates for BC are pretty similar to other jurisdictions. I've also highlighted Quebec, which is a province I'm going to come back to and I think beat up on a little bit later this afternoon or this morning, because it's a province that has historically been roughly in the pack in terms of drug spending in Canada. And then as a function of changes in the way that they finance medicines in Quebec, largely, the expenditure growth in that province escalated to levels that weren't seen in other provinces, at least for the better part of over a decade. Just so that we don't think that age is a factor in terms of explaining differences in provinces spending on medicines, a few years ago we published an atlas of prescription drug spending in Canada that did age standardized measurement of prescription use and spending for a wide variety of therapeutic classes and overall. And the point here is that we see, even adjusted for age of populations, very significant differences in spending per capita on prescription drugs in Canada. And just to put some color to this, if British Columbia was to spend per capita on prescription drugs at the same rate that the national average was, the province, both private and public payers in that province, would spend approximately $700 million more per year, every year, on prescription drugs than they do right now. Similarly, if Quebec was to spend at the rate of the national average, as opposed to the rate that they do on an age-adjusted basis, Quebec as a province, both private and public payers, would spend about $600 million less than they do today. $100 million there, $100 million here, pretty soon you're talking about real money. And the question is British Columbia underspending, or is Quebec overspending? So in order to answer that question, and this was I think, quite fun looking at the international data on prescription medicines, which I confess I hadn't looked at for a few years, and going back to the OECD database on health spending and looking at prescriptions once again, and actually pharmaceutical spending in particular once again, I realized that Canadians really need to start paying attention to more than just our American counterparts, who we are influenced by way of heavy or direct-to-consumer advertising of prescription drugs alone. But these are the data for a selection of OECD countries in terms of per capita spending, inflation adjusted, from 1985 to 2010. These countries are the 7 comparator countries that Canada uses for its international reference pricing regulations by way of the Patented Medicine Prices Review Board. I've added New Zealand and Australia, who are the bottom of the pack and exactly the middle of the pack in this slide deck, just because they're common reference points for doing pharmaceutical policy analysis. The main point of this slide, and actually the main point of surely an editorial I ought to write after this meeting, is that Canada, up until about the mid-1990s, was approximately equal to, in terms of spending on pharmaceuticals, equal to the median of these countries that we would routinely compare ourselves to. Since approximately 1995 or 1997, it appears, Canada has pulled away, and as you can see, the United States has pulled away in dramatic fashion vis-a-vis those other countries. There's a variety of things that might explain this. Canada and the United States are the only two countries in this pack that don't have universal systems for financing prescription drugs. In fact, we are the only countries in any form of comparable sets of countries that we might look at for Canadian policy studies that don't have universal systems of financing prescription drugs. I don't mean single payer systems, because there are a variety of countries, even illustrated in this, like Germany, France, and others, that are multi-payer systems in the context that they have social insurance structures for their medicines coverage, but they're universal. And as a function of that, they may have greater incentive for cost control. The other factor that North America has in terms of influencing medicines that other jurisdictions don't is that the Americans loosened restrictions on direct-to-consumer advertising in 1997, coincidentally the time when both those curves in Canada and the US pull away from the rest of the pack. And those advertisements that you see regularly as Canadians watching American media aren't found around the world. Yes, there are disease awareness ads around the world. Yes, there is a small amount of marketing message reaching the patient, so to speak, but not nearly to the same extent in terms of signal ratios. So, one of the hypotheses may be that in an era where there were a lot of Me Too drugs being brought to market, the industry, at least in North America, had a powerful mechanism of convincing people that they really need the latest version of what really might be considered old stuff. And then, again, to put some color on this, which is what probably will reach the editorial or the op-ed pages once I've managed to craft the editorial on this, is that the difference now between us and the median of those comparator countries, now remember we were at the median in the mid-1990s and now we were far above it. The difference is equivalent to $8 billion in spending every year. That's billion with a B. You know, this is real money. And of course, as Bob Evans has often points out in his presentations and in his teaching, every dollar of somebody's of expenditure is a dollar of somebody's income. It won't be easy to bring that curve back down to the international median, but it may be the right thing if we think that these peers, these 7 or now 9 comparator countries, are not a bad group to think about in terms of referencing our spending levels. It's not clear, for instance, that we would think that Switzerland, Australia, and other countries are grossly underspending on medicines vis-a-vis the United States, which would be the only comparator that is above us. So how do we cap spending on prescription medicines? And this is the narrative I think I was supposed to talk about. What are the effective tools for cost control? And it's actually sobering if you read the literature. There's a very good resource for people interested in finding evidence on medicines influencing policies, and it's the RX for Change database at the Canadian Agency for Drugs and Technologies and Health. It's a database of systematic reviews, in effect, about cost control mechanisms in pharmaceuticals and other mechanisms to influence quality of care in healthcare. But it's a great database. In a sense, you know, that it kind of answers many of the questions if you read through systematic reviews of the instrument you're interested in. But just to walk through a chronology, I guess, of the kinds of tools that we've tried to use in the Canadian context, I just want to say that we started, and in fact we still have, the historic legacy of fairly blunt instruments to try to manage the demand for medicines. And this is true whether it's pharmaceutical policy in Canada or health policy in many countries around the world. The idea of adding a co-payment or co-insurance as a mechanism to sort of ease up the demand side pressures for healthcare is it's great rhetoric. It's intuitive at the first instance. The literature is fundamentally and overwhelmingly convincing that the use of co-payments and co-insurance for pharmaceuticals tends to provide barriers to access to medicines that we might consider being essential, that is, the medicines that we want patients to take because they actually do something for their health that might help us as a system, i.e. keep them out of hospitals. It is co-payments and co-insurance are as likely to stop the utilization of those medicines as they are to stop the utilization of discretionary medicines. And so, in a sense, these instruments can be proven, whether it's applied in the Canadian context or around the world, to be the equivalent of penny wise and pound foolish. Part of the reason is that those instruments were really blunt. And so in the 1980s and 1990s, governments in Canada began to use instruments that were a little bit more sophisticated about, well, if we want to provide financial incentive for behavioral change, what we really want to do is get incentive for changing behaviors around things that have cost implications without quality implications on pharmaceutical use. And of course, this really relates to things like using a generic when a generic is available and priced lower than a brand whenever possible, or using a lower cost alternative within a therapeutic marketplace when there's no reason not to. So Canada actually started with generic reference pricing in approximately the late 1980s and through the 1990s, and by now actually all provinces in this country have various policies that basically tell the patient that if you want a brand, and a generic is on the market, you will pay the difference. There are a couple of provinces that actually have policies that say we won't even subsidize your brand at all, but basically these reference pricing for generic is to say we'll pay for the equivalent of the generics, and if you want the brand as a patient, you can top it up. In the chapter that I've submitted for this book, I actually pulled a figure from my thesis, which was fun to do because it's unpublished, and so I hope it gets into the book. But we can show that these policies have an amazing ability to increase the penetration of generics into branded marketplaces, and they're truly effective. Patients still fill prescriptions, but they fill the prescriptions at lower of the lower cost alternatives. This is really important now because globally, roughly $100 billion of drugs are falling off patent owing to the cliff, if you will. You saw that steep decline in drug development that occurred in the 1990s. That created what people call a patent cliff, where there's no new brand name drugs in these older therapeutic markets behind those medicines. So there's a mass genericization of markets around the world, and in developed countries, $100 billion worth of savings for payers, according to IMS Health. Again, $100 billion, it's real money. Canadian provinces have been responding to this by way of revisiting our historic legacy of pricing generics basically according to thresholds relative to brand name drugs. And owing probably to the fact that we used to have compulsory licensing of drug patents, we've accepted 30% off a brand as a reasonable discount. In the 1970s, when we were the only comparable country that had generic versions of patented drugs, 30% off probably seemed like a decent price. In the 2000s, where we have a full patent, pharmaceutical patent like everyone else in the world, 30% off when a product has had its 12 or 13 years of market exclusivity and falls off patent, 30% off for the generics is not enough. International evidence suggests that generic prices can be as low as 90% off or 1/10 the price of a brand. And as a function, provinces have begun to ratchet down the acceptable prices for generics. This has been hotly contested because if you think the difference between 30% off and 90% off, someone was making money selling those generics in Canada. And it turns out that the actor of interest was probably pharmacies, particularly the chain stores, who actually had generics in effect competing by way of discounts and rebates to the pharmacy for the privilege of having their generic on that pharmacy's shelf. Powerful incentive, but luckily provinces are starting to rein in on it. Therapeutic reference pricing, this is a great policy issue in the Canadian context because we have a lot of discussion about this issue because British Columbia in 1996 actually implemented therapeutic reference pricing, but implemented it for just a handful of drug classes. The idea here is to basically do the same thing that you did with generic reference pricing, but to expand it to a group of drugs that are relatively comparable in terms of their population level evidence of benefit to patients. In effect, what you say is that in a group like ACE inhibitors for hypertension, you will pay for the lower cost ACE inhibitor, and if a patient wants a higher cost ACE inhibitor without there being clinical evidence to demonstrate that they need it, the patient pays extra. Well, in the British Columbia context, this worked. British Columbians switched to the reference drugs in the drug categories that this tool was applied to overwhelmingly. And it worked in terms of shifting the patterns of prescribing in the province. It did not work in terms of the ability to shift the prices and create a more price competitive market. And one of the reasons for that was that we are in a world of international reference pricing. Canada does this because our Patented Medicine Pricing Review Board, in effect, is an international reference pricing agency, where countries around the world look at the prices that their neighbors are paying and say, I want to pay no more than they do. We do this. This is our regulatory scheme in the country, at a federal level anyhow. The problem with it, and it's been pointed out by the OECD and the World Bank, is that when everybody does this, the tool becomes useless. And it is becoming increasingly the case that manufacturers of brand name drugs around the world are now refusing to provide transparent discounts on prices. They're refusing to compete on price in a transparent fashion because they know that if they do that, they're going to have to pass those savings on to payers around the world. So what we have is this increased use of off-invoice, sorry it's early for me, or actually late because I still feel like I'm up from last night. Off-invoice discounts are used routinely now by payers around the world, and it's estimated that currently there are around $60 to $65 billion worth of these deals being struck between manufacturers and payers for medicines around the world, and it's expected to grow to 65 to 75 billion by 2015. I think this is a conservative estimate. I host a meeting once a year with policymakers from about 12 countries, including Canada. We have great representation of Canada on this network. And I know around that table, virtually every country is now engaged in these negotiated discounts in ways that they would have never thought of before. Not never. The Americans have been doing this always, but the rest of the world is now kind of catching up, so to speak. In the Canadian context, we just did a survey, which I hope the editors of the CMAJ will find reasonable enough to publish, but we did a survey of drug plan managers in the country to ask them how often they funded and used negotiated agreements on 25 drugs recently reviewed by the Canadian Common Drug Review. Ontario, of the 25 drugs we asked them provinces to look at, Ontario used contracts on 20 of those 25 medicines. BC's second most frequent use of these negotiated agreements used at for 7 drugs, Manitoba 6, Saskatchewan and Alberta 3, New Brunswick and Nova Scotia 1, and Quebec, PEI, and Newfoundland and Labrador none. What this means is that payers in this country are now paying different prices as governments. Ontario is probably paying a lower price on those 20 drugs that they have a contract for than other jurisdictions. Notably, Ontario is leading joint negotiations where other provinces are welcome to actually share in the deal that they strike with manufacturers. So the Ontario government is doing, I think, the right thing here. But it's notable that the other provinces aren't on board with this kind of tool, which is now routinely used around the world. And most problematically is that Canadian patients don't get the benefit of this. Our governments, although they're doing this, they only fund about 40% of the drug purchases in their provinces. The other 60% of purchases, in effect, pay what are artificially inflated list prices, the equivalent of the dealership price for a car, which frankly nobody should ever have to pay. And why is this a problem, or why does this happen in Canada, and what is the fundamental challenge in our system? And I apologize, I'm going to eat into a minute of my extra time here. We have a problem in Canada because it's too easy to pass the buck. I mentioned that Canada and the United States are the only systems without universal coverage for medicines. This is an important issue because unless a system is responsible for funding medicines, it could be a multi-payer system like social insurance is found in Europe, but unless a system is responsible for funding everything, it's really difficult to control costs because it's easy to pass costs around. This figure is British Columbia per capita spending on prescription drugs from 1995 to 2011. The point here is that this is the province we think of as being exemplary for cost control. I defy you to show where the British Columbia government has managed costs since 1996. Those lines that I've illustrated here, the first one is when they introduced generic reference pricing in British Columbia, which clearly actually flattened the cost curve temporarily in BC. The second line is therapeutic reference pricing. I'm a big fan of therapeutic reference pricing, don't get me wrong. I thought the tool was brilliant at the time. It was only applied to 5 drug categories in 1996. I mean, we can't have thought that was truly going to bend the cost curve. 5 classes out of what is literally hundreds is not enough action, so to speak. The other curve that's interesting is the bottom half of this curve, which is provincial payment for medicines versus the top half, which is the other sources of payment. British Columbia passed or reformed its pharmacare program to become an income-based pharmacare program named Fair Pharmacare. This is a dominant model now, this notion of catastrophic drug coverage from government and let the private sector take care of everything else. You can see this was a powerful tool for governments. There's no question that governments across the country like this tool. Look at that bottom curve. They bent the public cost curve for sure. the liability of the public sector for medicines in British Columbia per capita has basically remained the same for a decade, which is powerful signal for governments. This is how we can get this off of our books. The problem is the top half of that chart. It puts it on everybody else's books. I'll end there. I apologize for going a little over. Thank you.